Hello everyone, my name is Tiara Brooks, and here at School-Based Health Alliance we would like to thank everyone for attending today's webinar titled Confidentiality, EHRs, and Patient Portals, A New Frontier. During today's webinar, we will explore challenges and relevant laws in the context of EHRs and patient portals in the health center environment and consider possible strategies. But before we begin, we have a few housekeeping reminders. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based health care. We believe that all children and adolescents deserve to thrive. When health and education come together, great things happen. First, please help us with our attendance count. If you are viewing as a group, please go to the question box and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones plus 3. This will help us with our final attendance count. Also, all attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the question box located in your GoToWebinar control window. We will address questions following the presentation. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be uploaded to our website. We also ask that you visit our website. On our webinars page, you will see a column for a 5-part webinar series on protecting adolescent confidentiality in healthcare, featuring our presenter for today, Abigail English. Until February 17th, viewers have the opportunity to watch the webinar series and submit additional questions to Abigail to info@sbhforall.org. The series does include this webinar. We truly look forward to hearing from you. Our presenter today, Abigail English, is a lawyer, researcher, and advocate for the rights of vulnerable youth. She is the director of the Center for Adolescent Health and Law. Abigail's research and advocacy have focused on health insurance and public financing of health care, consent and confidentiality protections, and sexual and reproductive health service. Again, thank you everyone for attending our webinar. I will now turn it over to our presenter today, Abigail English.
Thank you very much, Tiara. I'm really excited to be on this webinar today, and I'm looking forward to talking with everyone about an issue that I know a lot of people around the country have struggled with for quite some time now, and I can't pretend that I'm going to have answers for all of your questions, but I think that together today we can begin to understand what the framework is, both from a legal perspective and from a practical perspective, in protecting the confidentiality of adolescents' health information in this era of electronic health records and patient portals. So what I'm going to talk with you all about today, it will include a brief mention of some of the benefits of electronic health records and patient portals, because I think sometimes we get very caught up in worrying about some of the downside risks, but there are many benefits. And then after mentioning a few of the confidentiality challenges related to electronic health records and patient portals, I'll give a very quick overview of the federal laws that relate to health information technology and how those laws interact with federal confidentiality laws and state confidentiality laws, and then share with you some recommendations that have come out over the past 3 or 4 years from professional health and medical societies, and take a look at a couple of practical approaches that have been undertaken and some specific recommendations both for the vendors of and creators of health electronic health records and for the health systems and healthcare providers and patients. And wrap up at the end with a few questions to ask and strategies to consider. So without further ado, I'd like to ask a question. Perhaps Tiara can implement this poll question.
Yes. Has your SBHC or sponsoring organization implemented an EMR or EHR? If you can please take a few seconds to answer the question. Thank you. Great. Thank you, everyone. Abigail, we have 92% said yes.
Well, I'm not surprised to hear that. What it tells me is that you all have been struggling directly and concretely with a lot of the issues that we're going to talk about this afternoon, and I suspect that some of them have electronic health records than I do. So I hope you can put questions into the question box, but also any comments that you have. So I want to start with a few definitions because there are a lot of terms that get tossed around and they're often used interchangeably, and that's mostly okay, but they do have slightly distinct and different meanings. These definitions were drawn from a position paper of the Society for Adolescent Health and Medicine, which actually took them from the HHS, the federal HHS government's website, healthit.gov. An electronic medical record, or EMR, really refers to a digital version of a paper chart. In other words, confined to one particular healthcare site or medical office or clinic. An electronic health record more often refers to a record that's shared among multiple providers. And a personal health record refers to a repository of information from multiple contributors, which could include, in addition to physicians and other healthcare professionals, the patient or the family. And it's a subset of electronic health records, and then personally controlled health records are a subset of PHRs, and they enable individuals to aggregate, store in a secure manner, and access information from multiple sites and then share them with healthcare professionals and with others who do so. And finally, health information exchanges are organizations that provide services to enable the sharing of electronic health records, electronic health information across multiple sites and individuals. So EHRs, I'm going to shorten this to just refer to EHRs and portals rather than using all of those different terminologies, because I think these are the terms that probably most of you are familiar with in your daily work. They can improve accessibility of health care by simplifying the making and reminding of appointments. Prescriptions can be refilled. Contact can take place between practitioners and patients electronically, which can often be an efficiency that really is helpful. And they can improve healthcare effectiveness. A couple of examples that come out of studies that have been done over the past few years have shown that EHRs and portals can help to increase vaccination rates and increase rates of preventive counseling for young people so under the Bright Futures standard. So those are very positive elements. Also, they can be used to improve healthcare safety. such as by reducing unnecessary antibiotic prescribing and identifying potential prescription medication conflicts. So there are many advantages from a patient and a healthcare provider point of view. In addition, if appropriately used, they can make population data available to researchers in ways that would not have been true without these electronic health records. However, there are numerous confidentiality challenges associated with the use of EHRs and portals. Just a few, and we'll revisit this later in the webinar, but just a few of those challenges include some risks for individuals that can result from inadvertent disclosures. In other words, that neither the healthcare provider nor the healthcare site is really intending to inappropriately disclose confidential information, and may even be thinking that they're protecting confidentiality for the adolescent patient in appropriate ways, but automated appointment reminders, problem lists, and medication lists that are included in after-visit summaries or AVSs, lab test results that appear on portals, and patient notes from the electronic health record that may be visible on portals all can result in inadvertent disclosure or sharing of information with, let's say, parents if the adolescent really does not want that information shared. In addition, there are ways in which data can be lost more systemically, such as, for example, if somebody loses an unlocked mobile phone, that can provide access to not just a particular lab test result, but all of the patient's information. And sometimes comprehensive data sharing agreements on health information exchanges also result in broad implementation at your particular sites. But the HITECH Act, which stands for Health Information Technology for Economic and Clinical Health Act, was enacted as part of ARA in 2009. And I'll talk a little bit more about HITECH in a moment. HIPAA, which was the Health Insurance Portability and Accountability Act that was enacted in 1996, also contains significant provisions related to health information technology, both in terms of privacy and in terms of security. The Affordable Care Act, which we don't usually think of as an information technology law, did contain some provisions, particularly that provide for funding and grants to sites, healthcare sites, such as, for example, community health centers or other similar sites to implement various health IT mechanisms. I'm not going to talk too much about those provisions today, but they were part of the Affordable Care Act and they have been implemented. And the notable thing about these various health IT provisions in federal law is that they really do not in any significant way address adolescent privacy concerns. The HIPAA privacy rule does, and I'll remind us of how it does that a little bit later in the webinar, but for the most part, these laws were not drafted with adolescents in mind and have not been implemented with adolescents in mind. So the HITECH Act, as I said, was enacted in 2009. It's a statute that gives the Department of Health and Human Services authority to improve healthcare quality, safety, and efficiency through the promotion of health information technology. And two of the major mechanisms for doing that are through electronic health records and a whole raft of different health records and through health information exchange. And one of the major threads.
Hi, Abigail. We can't really hear you that well.
I'm sorry. Can you hear me now?
Yes,
Oh,
thank you.
I'm sorry. I think I may have muffled the microphone. I apologize. Let me know if it happens again. So one of the major threads of high-tech implementation has been the meaningful use requirements, which may well be familiar to many of you. The authority to implement the HITECH Act, as well as other health information technology requirements of federal law, rests with something called the Office of National Coordinator, the ONC. And I'm not going to talk particularly about the ONC today, except to mention it at the end with respect to some strategies. But it is an important sort of central coordinating office for a myriad of federal legal requirements and programs related to health IT. And finally, the HHS has a website for health IT implementation of these laws, and it's healthit.gov, and it has a lot of very useful resources on it. So the next poll question is here now.
Yes. The next poll question is your sponsoring organization or SBHC implementing meaningful use? If you can please select a response. Thank you. Okay, great. Thank you, everyone. Abigail, 66% said yes, and 22% doesn't know, and 12% no.
Great. Well, thank you so much. That's really very helpful information. And I am not surprised, because I think a lot of people may be implementing meaningful use without realizing that that's what they're implementing. They're just, doing certain required things and aren't familiar with the label, and other places are not yet doing it. So let me explain a little bit about what meaningful use is. The HITECH Act established financial incentives under Medicare and Medicaid to promote what is referred to as the meaningful use of certified EHR technology. And that is designed to improve and ensure the recording of patient information as structured data, promote the exchanging of summary records, and improve outcomes for patients. And this has been a multi-stage process that began back in 2010. The first two, there are 3 stages. The first 2 stages have already been reflected in regulations and that relate to the electronic capture of clinical data. That's the EHR, the EMR. The provision of electronic copies of health information to patients, which primarily takes place on these patient portals. And then continuous quality improvement, which I'm not going to talk about today, and exchange of information in the most structured format possible, which is technical and in a way that's really beyond my expertise. But if any of you have comments on it in ways that are relevant to adolescents, you can share those with us at the end, and I would welcome that. So in addition to the HITECH Act, HIPAA has many requirements that relate to health IT. As I mentioned, the statute, the HIPAA statute, was enacted all the way back in 1996, more than 10 years ago now. Primarily, we're familiar with HIPAA through the regulations, and those regulations are contained in two big parts of the HIPAA regulatory structure, the HIPAA privacy rule and the HIPAA security rule. And the Office of Civil Rights within HHS is charged with implementation of these two rules, particularly the HIPAA privacy rule. And some of you may have seen in the news media from time to time that various large fines are imposed when massive violations of the HIPAA privacy rule occur. This is not when one individual's information is disclosed, but when, you know, an entire hospital system fails to protect a large body of information. It sometimes has resulted in some sort of a fine. So I think maybe if you're like me, and maybe you're different, you are more familiar with some of the aspects of the HIPAA privacy rule than the HIPAA security rule. But the HIPAA privacy rule is the part of the HIPAA regulatory structure that does contain some protections for adolescents. And I'll speak about those in just a moment. The HIPAA security rule, which contains a lot of very technical information related to the safeguarding of electronic protected health information. The details of that are perhaps less familiar unless you are directly involved in some of the IT implementation at your site. So it's important to remember that there are not just the HIPAA privacy rule, but a host of federal confidentiality laws that have a bearing on this topic. It's important to remember that the HITECH Act and the Health IT provisions of the HIPAA regulations are not implemented in a vacuum. They're implemented in the context of a host of other federal and state laws, including federal and state confidentiality laws. So it is not only what appears in the HITECH Act itself, but how that's interpreted in relation to these other federal laws that require confidentiality protections. The big one, of course, and the most obvious one in relation to HITECH is the HIPAA privacy rule, but there's also the Title X family planning confidentiality regulations, Medicaid confidentiality protections, the drug and alcohol confidentiality regulations, the Ryan White HIV/AIDS program, the confidentiality rules for Section 330 federally qualified health centers, which read very similarly to the Title X family planning rules. So there's a myriad of federal confidentiality laws that have to be taken into consideration when implementing the HITECH and HIPAA IT requirements. Just as a reminder, the HIPAA privacy rule sets forth a series of rights of individuals, and that term individual is a term with legal significance under HIPAA. And individuals have, people who are considered individuals have the right to control disclosure to a certain degree of their protected health information. They have a right to access their records, and they have a right to request special confidentiality protections in the form of asking for confidential communications or asking for restrictions on disclosure. The question of when parents have access to a minor's protected health information turns on whether the minor is considered an individual under the HIPAA privacy rule. Ordinarily, a parent is considered the authorized representative of their minor child and would therefore have those rights that are enumerated above to control disclosure, access records, or request special confidentiality protections. But in those situations where minors are treated as the individual, then the minor assumes those rights in general. And minors are considered individuals if they have the right to consent for their own care and do so, or if the minor and the parent and the provider, the parent has acceded or agreed to confidentiality, that confidentiality may take place between the healthcare provider and the patient. In both of those situations, the minor is considered the individual. And when the minor is the individual, the issue of whether the parent has access to their protected health information turns on state or other applicable law. So the parent is no longer automatically the authorized representative. The minor can request that they be the authorized representative, but they don't get to do that automatically. And so when parents want access to the information or records of a minor who's considered an individual, you have to look at state or other applicable law. Well, other applicable law includes those federal confidentiality laws that I spoke about a moment ago, and it also includes state confidentiality laws. Now, I'm not going to review this long list of state confidentiality laws, but this is here just as a reminder to you that there are many in any given state. And two of the key kinds of state confidentiality laws that are relevant, particularly with respect to electronic health records and patient portals, are the minor consent laws, which sometimes contain explicit confidentiality provisions and are sometimes cross-referenced in other laws, and state medical privacy laws, which in many states contain specific provisions implementing or incorporating the requirements of the HIPAA privacy rule into state law. And just to remind you, all 50 states in the District of Columbia do have those state minor consent laws, either allowing minors to consent based on their status or allowing minors to consent based on the services that they're seeking. And some, although not all of those laws, contain provisions directly addressing the question of whether information about the services or the services that the minor has consented to can be disclosed to their parents. Sometimes those laws say it may be disclosed. Sometimes it says the law says it may be disclosed if necessary to protect the health of the minor. Sometimes it says it may be disclosed. It may not be disclosed unless it's necessary to protect the health of the minor. And there's quite a bit of variability among the states and even within individual states with respect to which status might enable a minor to consent, which services a minor may be able to consent to, and whether the information about the services can be disclosed to their parents. So in addition to the confidentiality laws at the federal and state level, there are also laws that require disclosure, and those laws also have a bearing on what occurs in relation to electronic health records and patient portals. So I'm not going to delve into detail about these, but as a reminder, the billing, insurance communications, and EOBs all amount to mechanisms whereby confidential information can be either inadvertently or intentionally disclosed to someone other than a patient. There are also mandatory reporting laws, which include laws that require certain kinds of reporting for public health purposes, and may include some confidentiality mechanisms, but not preclude those reports from taking place. And then, of course, child abuse reporting laws. And most states, either in statute or case law, have requirements that if a patient is a danger to himself or herself or to others, information must be disclosed either to law enforcement or to some other individual or entity for the protection of the patient or the protection of third parties. And finally, there are parental notification requirements. Now, I want to stress here that very few of the minor consent laws that I mentioned on the previous slide contain actual requirements to notify parents. They may contain permission to notify parents, but not requirements, with the exception of abortion, which, as I know, is not provided in school-based health centers, but it's important to remember that that's one area in which a very large majority of the states have acted to require either parental consent or notification. So with that as the backdrop, I want to start looking a little bit at customization. So we're at poll question number 3 here, Tiara.
Yes, if your site is using EMR, EHR, or patient portal, has it been customized to protect adolescent confidentiality? If you can please take a few moments to answer the question. Thank you. Okay, we have 35% for both yes and no, and 30% don't know.
Great, thank you. That's very helpful. So I'm not surprised by that answer either, because I think that some of these mechanisms to protect adolescent confidentiality are not always so obvious. And I know that a lot of sites that are using EMRs, EHRs, or patient portals have not yet, through no fault of their own often, been able to customize those tools to protect adolescent confidentiality. And we'll talk now a little bit more about why that is and what might be able to be done about it. So over the past few years, 2 of the leading medical organizations, professional organizations that address issues in adolescent health have come out with recommendations. The AAP, the American Academy of Pediatrics, in 2012 issued a policy statement on standards for health information technology to ensure adolescent privacy, and the Society for Adolescent Health and Medicine endorsed that policy statement. And then in 2014, SAHM came out with its own recommendations for electronic health record use for delivery of adolescent health care in a position paper. So the AAP recommendations set forth some criteria that they thought were important for electronic health record systems, that they should include privacy standards for adolescents, they should explicitly provide for determination of who has access to or can control access to the EHRs and the portals. The term EHR and portal were used a little bit interchangeably here. Mostly the term used was EHR, but sometimes it really referred to aspects of the portal. The recording of authorizations and consents by adolescents, both consents to care and consents to disclosure or consents to authorization of access. Explicit consent by adolescents for release of specific PHI, such as lab results or other specific information. Flexibility to protect specific elements of the record or the entire record. Making sure that privacy standards are consistent with state laws. flagging data for placement in a confidential section of the EHR, and protection of aggregate data, and then finally billing systems that can suppress billing to a parent when the adolescent is entitled to confidentiality. So that was 2012, now 5 years ago. The AAP made clear in that policy statement that these criteria were not yet being followed in a large number of EHR systems, or had not been implemented in a large number of EHR systems. 2 years later, when the Society for Adolescent Health and Medicine issued its recommendations, they issued several similar recommendations. Their recommendations broke down into 4 groupings: those for vendors and EHR systems, those for healthcare systems and sites, those for healthcare providers, and those for patients and families. With respect to EHR systems, SAHM recommended the development of very granular privacy controls and robust privacy settings, allowing, as the AAP had recommended as well, for designation of specific elements and information as confidential and suppressible, differentiating access to information between the parent and an adolescent, limiting the sharing of unauthorized information via a health information exchange. I think one example of that is when information is shared across providers in different sites and may include, for example, medication lists that have been, lists of medications that have been prescribed and filled at a pharmacy, which can reveal confidential information. And then default privacy settings that can be overridden. With respect to healthcare systems, SAHM stressed the importance of the commitment of the institutions to protecting adolescent privacy, and the need, if systems had been customized to do so, to train staff at every level of the organization in order to make sure that those customized protections were actually implemented. For healthcare providers, knowing the laws and acting as champions within their institutions was seen as extremely important. And finally, SAHM said, you know, patients and families should not have to advocate for confidentiality protections, but they do. And when those protections are in place, they need to use the systems in ways consistent with those protections. So I want to turn now to 2 different documents that contain information that I think is very helpful in this context. The first is a set of special requirements for electronic medical records in adolescent medicine that appeared in an article in JAH, Journal of Adolescent Health, back in 2012. And that article preceded both the AAP policy statement and the SAHM position paper, and really addressed some of the technical issues in a pretty granular way that's beyond the scope of what we have time to talk about today, but I can share a little bit of it with you. The confidentiality issues, they said, are really ones that can crop up for adolescents at every step of the process of an adolescent engaging with a healthcare system. And just with respect to outpatient care, they highlighted several mechanisms whereby confidentiality issues can arise. The making of appointments and communications related to the making up of appointments, changing times, follow-ups, reminders, etc. All of the steps involved in meeting the requirements for meaningful use with respect to electronic information is riddled with opportunities for confidentiality issues and challenges to arise. Medication lists, problem lists, behavior lists or behavioral documentation in electronic health records that then gets transferred into after visit summaries and other parts of the electronic health record that appears on the patient portal can all raise confidentiality concerns, as can prescriptions and prescription refills and lab results. And then, of course, the posting of bills and after visit summaries on portals can also raise confidentiality issues. So one set of the recommendations, there are numerous sets of recommendations in this document, but one specific set that is highlighted is recommendations for vendor action items. And this document used the term EMR, but really I think they were using it in a way that has now been sort of shifted over to the term EHR and even patient portals. The recommendation, the vendor action items that were recommended included the implementation of adolescent privacy default settings and granular customizable privacy controls, point of care privacy controls for physicians, so not just at the whole hospital system, but in the individual clinic or health center, clear on-screen labeling of confidential data, built-in privacy-related decision support tools, robust patient adjustable proxy access for portable portals. In other words, adolescents being able to make adjustments to access authorizations, and then the ability to suppress AVS's bills and post-visit surveys. And at this time, 4 or 5 years ago, the recommendation was for joint development of adolescent privacy standards with the Office of National Coordination. I don't know whether that is going to be a wise recommendation going forward at this particular moment in time, but that's something we could talk about at another time. I do not believe it has taken place so far to any significant degree. The other, another study that I want to highlight for you, because I think it really contains some very interesting information about one particular site in Florida at an academic health center that had 3 primary care clinics. And they decided to, at one of those primary care clinics, adapt an adolescent patient portal that was specifically designed to meet adolescent patient needs. And this was the basis for a research study that took place in 2012 to 2015. They considered 3 different adolescent patient portal models, one being confidentiality, which really gave the confidentiality protections virtually and the access virtually entirely to the adolescent. The second was a family engagement model which shared access between the adolescent and the parent. And the third was a parent orientation model. What they chose to do was to implement the confidentiality model for adolescents ages 12 to 17 and the parent orientation model for children ages birth to 11. And they did this over, and then they tracked the use of the portal in various ways over a 2.5-year period. They had 963 pediatric portal users for 100% parent as proxy. In other words, the parent was acting for the child in 100% of those situations. And 937 adolescent portal users, and in only about 6% of those situations was the parent given access by the adolescent as their proxy. In the rest of the cases, the adolescents were acting on their own behalf. And in that adolescent, in the use of that adolescent portal, the click-through rate varied. In other words, that was the rate at which the individual using the portal went beyond the home page. Only 37%, but 37% initiated messages to the healthcare provider through the portal electronically. 67% viewed lab tests and results, and 78% interacted with the medication portion of the portal. And of those 37% who sent messages to their provider, 89% of the providers sent messages back to the patient, and that was a higher percentage than was the case in the providers responding back to parents who sent messages in the pediatric portal situation. So that was I think it's the only study I'm aware of that actually looked at what the effects are of implementing an adolescent portal that has a very high level of protection for the confidentiality of the adolescent. I'm going to wrap up here and turn to our question portion by highlighting a couple of questions that can be asked going forward and strategies to consider. So if you're at a site where you don't know whether any specific protections have been implemented in your EHR or your patient portal to protect adolescent confidentiality, that's a really important first question to ask. Another important question to ask is whether the vendor, be it Epic or one of the other vendors, has the vendor been responsive to requests to customize the EHR in order to protect adolescent confidentiality? Or is there an in-house capacity to customize? Now, there are some advantages and disadvantages to each of those approaches, the vendor customization and the in-house customization. The vendor customization has the advantage that if and when the vendor, there are updates to the system coming from the vendor, the customization will be preserved, but it can be very expensive. On the other hand, in-house customization can be less expensive, but sometimes those customizations are lost if the vendor issues an update and that update is implemented, so the customization would have to be reincorporated. So what are some strategies that we can consider going forward? Well, one is to advocate with your sponsoring organization to customize your EMR, EHR, or portal to provide protection for adolescent confidentiality, or if it already does that to some degree, to improve that protection. And another is to form or participate in an internal task force of some sort to develop or improve adolescent-specific standards for the EMR, EHR, or portal. This is really important because very often those individuals who are involved in making the decisions about the health IT at a particular institution, particularly a large institution that does not serves far more than adolescents, younger patients, older patients, patients with complex and chronic conditions and everything else, often those decision makers are not well enough informed about the needs of adolescents and the implications and potential for inadvertent disclosures and the implications of those disclosures. So I'll close there and turn this back over to Tiara. I do have some resources listed here, the ones that I referred to in the course of the webinar, and then you can look at those yourself because they contain much more detailed information than I was able to include here. But I thank you for your attention, and I look forward to responding to your questions.
Thank you so much, Abigail. We would love to give everyone the opportunity. If you have any questions, please enter your questions now in the question box. And while we give others a few opportunity to enter their questions, we do have just a few announcements. We do want to just remind everyone about our membership. School-Based Health Alliance works to improve the health status of children and youth by advancing and advocating for youth health care. In addition, our members receive exclusive access to valuable programs, tools, timely publications, and networking opportunities. Please take a moment after the presentation to visit the website for more information. And also, please mark your calendars for our 2017 National School-Based Healthcare Convention, June 18th through the 21st in Long Beach, California. Please join School-Based Health Alliance, the California School-Based Health Alliance, and your peers from around the nation for 3 days of engaging workshops, networking, and fun. More information about this is coming very soon to our website, so please look forward to it. All right, so now we want to open it up for any questions that anyone have for Abigail. If you can please enter your questions in the question box. Okay, and Abigail, while we're still waiting, is there any, maybe one more minute, but any additional information you want to add from your presentation today?
Yes, I can add something that I didn't take the time to talk about. Over the past year and a half, I've had the opportunity to travel to a number of states around the country and talk with providers, policymakers, and other advocates about issues related to confidentiality in the context of billing and health insurance communications. But everywhere we went to talk about those issues, we encountered people who were struggling with the questions around electronic health records and patient portals. And I only shared with you today the experience from the one study that was reported from the Academic Health Center in Florida. But there are folks that we've talked to in Maryland, in Illinois, in Washington, in California, in Colorado, in a variety of settings, from children's hospitals to academic medical centers to Title X family planning and Planned Parenthood health centers to school-based health centers that are really trying very creative efforts to deal with these issues. Now, nobody that I've talked to yet has come up with an airtight or comprehensive solution. One of the strategies that seems to be used is to do what they did in Florida, which is sort of allow parent access until age 12, close down parent access after age 12. That has advantages and disadvantages because, as we know from confidentiality studies that have been conducted over several decades, not all adolescents require or ask for or insist on confidentiality at all times for all purposes. So often adolescents are willing and anxious or interested or desirous of sharing information with their parents about health issues, either health issues that are not so sensitive, in other words, that are not related to reproductive health or substance abuse or mental health issues, but are related to other things, or even sometimes issues that are related to those things. Now, the fact that the adolescent portal in Florida, only 6% of the adolescents chose to give proxy to their parents, I don't think is sort of the final word on that, because I don't know whether that system was structured in such a way that they sort of had to give them access to everything or nothing. And clearly the recommendations from the AAP and from SAHM and from the experts who wrote that requirements article in JAH are that what's needed is not wholesale solutions, but very granular solutions. And the challenge with granular solutions is that they can be really customized in very specific ways, but then you have to train people on how to use those granular customized solutions. And so it's kind of a balancing act. You know, how do you get the maximum confidentiality protection while sacrificing the least parental support that can be desirable and helpful and even necessary? I will add that in that Florida example, they operated that adolescent portal with the agreement of parents. In other words, parents had to agree that the patient, the adolescent patient, would be able to use a portal that was within their own control. So that was an important element of that system. So I think that's the main thing I'd like to add to what I talked about earlier.
Okay, perfect. Thank you so much, Abigail. We do have a few questions for you. The first one is, we just got a patient portal started. We need to create policies. Any guidance on where to find some sample policies for general patients and adolescents specifically?
I wonder what state that individual is in. I don't know of specific policies that are generally available,
Pennsylvania.
but depending on what state you're in, a couple of different places that I would start would be to contact, if there's a children's hospital in your state. I know the children's hospitals have been working very hard on this. They might have policies that they'd be willing to share. Some of this is proprietary information, but some of it can be shared. Another source I would go to is Planned Parenthood or Title X family planning sites. Another source I would try is community health centers, because they have received some grants, as I mentioned, under the Affordable Care Act to implement meaningful use, which involves patient portals. So they might have some policies, although their policies might not be tailored to adolescents depending on the community health center. Those are a few thoughts.
Okay, thank you, Abigail. Our next question is, are you aware of any institutions that have developed best practices for using various EHR systems when caring for adolescents?
Well, I think that's very similar to the question that I just responded to. I think that the children's hospitals are really, I think, have been in the leadership on this, along with some of the other academic medical centers. I know Children's Hospital of Philadelphia has worked on it. Children's Hospital of Colorado in Denver has worked on it. Children's Hospital in Seattle a little bit to some degree. Also, some of the group and staff model HMOs like Kaiser and Group Kaiser in California and Colorado, and Group Health in Washington State. Those places have worked on developing standards. I don't know if you could literally call them best practices. I think the closest we come to best practices are what's found in the 3 documents I cited from AAP, SAHM, and the JAH article on requirements.
Okay, perfect. Thank you. We're going to try to squeeze in 2 more questions, but I do want to ask Abigail, it's okay if we send out your slides to the audience, if that's okay?
Yes,
After the webinar.
you'll convert them. You'll convert them to a PDF
PDF,
format.
yes.
Do that. Yeah,
All
that's
right,
fine.
great. So we'll send that right out after the webinar. Is it a privacy breach to have a healthcare institution contact an adolescent's family about compatible insurance when the visit was for reproductive health care or behavioral health services?
I'm sorry. What was the word before insurance?
Compatible
Okay.
insurance?
Okay. I think that that is a question that can't be answered in general, but it does raise red flags. But the specific answer to that particular question would require taking a look at the laws in the particular state where this was taking place and the particulars, and also in the context of the particular setting where the services were provided.
Okay, great. Thank you. Hawaii just passed a minor consent laws. Do you have any EHRs that are rated as best of maintaining confidentiality for adolescents?
I feel like I'm repeating myself here, but I don't have specific suggestions beyond the ones that I made. I really think that if you were to take a look at the 4 documents, or at least the 3 documents that I cited, they contain some pretty detailed recommendations, much beyond the detail that I was able to include in today's webinar in the time available. So I would recommend taking a look at those documents, and then if you have further questions, you could take advantage of this 1-month period that the School-Based Health Alliance has made available to send in questions, and I probably won't be able to respond in writing to all of them, but I will respond to as many as I can.
Thank you. And we do have quite a few questions. So can we forward those questions to you after the webinar, Abigail?
Yes, you certainly can. If they're ones that I can answer quickly, I'll be glad to do that. If they're ones that require more elaborate answers, maybe we can incorporate them into the pool for that 1-month period.
Definitely. So we do have quite a few questions, and we will enter them with the questions for our webinar series, and we apologize that we can't get to all of them today for our webinar, but we do appreciate all the questions that you have for Abigail. But before we do close, we do have a few questions for you. We would like to know, did this presentation meet your needs? If you can just please take a few moments to answer the question. Thank you, everyone. And how well did the presentation meet the stated objectives? Okay, and how likely are you to apply the information from this presentation in your organization? And would you recommend this webinar to others? Okay, again, thank you everyone. I have provided here again Abigail's information and the website. Abigail, thank you so much for this presentation. This was amazing information and we truly appreciate it.
Well, thank you, Tiara, and thanks to all of the participants. I was happy to be with you this afternoon.
Okay, thank you, and we will follow up and submit your questions. Have a wonderful day.